Okay, now it's time for the session of ongoing trial from the Asan Medical Center. So I am Kim, is moderator of this session, and also co-moderation is Fearon. So would you come up to the stage, panelist? Okay, the first talk is Dr. Hanbit Park. His talk is a tailored chip trial. Yesterday this trial was also we discussed by the DW. So his talk is a temporal dynamic antiplatelet strategy for complex high risk PCI. Dr. Park, please.
Thank you, Chairman. It's an honor for me to introduce our upcoming trial, tailored chip trial. Tailored chip trial is tailored antiplatelet regimen versus the conventional antiplatelet regimen in complex high-risk PCI trial. This is my disclosure. In current guideline, depth duration and depth potential is recommended according to clinical manifestation. Stable coronary artery disease and this 6 months depth, and acute coronary syndrome at least 12 months depth. However, currently we perform many PCI with the complex high risk patient. High risk patients is previous non-STEMI or STEMI, or the current ischemic depth, events on depth, and history of stent thrombosis and chronic inflammatory disease and diabetes and chronic kidney disease. And anatomic factor with the high risk PCI is 3 more stent and total stent is above 60 millimeter, and complex PCI CTO and complex bifurcation and multiple PCI and PCI with bioreserve stent. In current guideline, prolonged depth duration may be considered in patients who underwent complex PCI. However, optimal depth treatment of complex high PCI is still unknown. So we designed our study with the study drug is ticagrelor. Ticagrelor is a reversible and direct acting oral antagonist of the adenosine D phosphate receptor P2Y12, provide faster and greater and more consistent P2Y12 inhibition than clopidogrel. In PROTECT trial, in acute coronary syndrome patient, ticagrelor reduced vascular death and MI or stroke without major bleeding. And we conducted our center in acute coronary syndrome. We evaluated the antiplatelet effect among clopidogrel and ticagrelor 60 milligram and ticagrelor 90 milligram. Though those ticagrelor 60 milligram was compared with the clopidogrel was more high potential P2Y12 suppression. However, low dose ticagrelor 60 milligram and standard dose ticagrelor was similar in P2Y12 inhibition. So we used low dose ticagrelor and we designed our tailored chip trial. A multi-center open-label randomized controlled trial comparing to different antiplatelet strategy in high-risk PCI patients with complex clinical and regional and procedure characteristics. This is our concept of study. After PCI in first 6 months, elevate increasing ischemic risk above bleeding risk, and next 6 months bleeding above ischemic risk. So our tailored regimen using aspirin and the ticagrelor 66 milligram. So early escalation for reducing ischemic risk, and next 6 months using only clopidogrel monotherapy. Next escalation using for bleeding risk, reducing bleeding risk. So our expansion regimen tailored antithrombotic strategy for 6 months is aspirin 100 milligram and ticagrelor 60 milligram, and next 6 months monoclopidogrel monotherapy. And control regimen is conventional regimen for 12 months aspirin plus clopidogrel. And tailored chip assumed 2,000 patients was required to our hypothesis, and 2,000 patients randomization 1,000 conventional arm and 1,000 tailored arm. Our study endpoint, primary endpoints are net clinical outcome of all-cause death and MI stroke, stent thrombosis and urgent revascularization and clinical relevant bleeding, BARC2, 3, or 5, and 12 months. Our second endpoint is each component of ischemic outcome and bleeding outcome. And including criteria, this is very important. Our at least one of any feature of chip patient. Clinical factor is diabetes and CKD and severe LV dysfunction. And lesion and procedure factor is left main disease and bifurcation with two-stent implantation, and CTO and severe calcification and deep long lesion and multiple PCI and three more stent and 3 lesion more treated and total length of over 60 millimeter. And exclusion is enzyme positive acute coronary syndrome and non-STEMI STEMI and cardiac shock patient and need for chronic oral anticoagulation and active bleeding or extreme risk for major bleeding. And history of intracranial hemorrhage and liver cirrhosis and planned surgery within 6 months and diabetes dependent renal failure. Current status is from February 2019 through January 2024, a total 2,000 patients were enrolled. Next year, the prime result will be available. So this is my last slide. We anticipate in future guideline, early escalation and late de-escalation, time modulated depth strategy should be considered in patients who underwent complex high-risk PCI. Thank you.
Thank you, Dr. Park. Next speaker is Dr. Jinho Lee. As his talk is ENAVO-TAVR trial. Yes, Dr. Lee, please.
Yeah, thank you for introduction. I'm very glad to present this TCTAP meeting. Today, my talk is about the ENAVO-TAVR trial. The full title is too long and short quickly, and the randomized trial to comparing SGLT2 inhibitor and placebo with the underwent TAVR patient. The aortic stenosis is the most common valvular disease in the aging population. So in old age population, the incidence of valvular heart disease is increasing. And the moderate to severe valvular disease show the worst outcome compared to normal valvular function population. But until now, the treatment of symptomatic AS is aortic valve replacement through the surgical or transcatheter approach. Especially, TAVR was expanded the indication include a low-risk patient and recommended in adult over 65 years old in US guideline and over 75 years in the European guideline. However, despite the mechanical relief of severe AS after TAVR, up to 50 patients are dead and have a residual heart failure symptom or poor QOL at 1 year. Especially the patient who underwent TAVR have approximate 15 to 20 rate of readmission for heart failure within 1 year, even after successful TAVR procedure. Now, this problem is from the concept of the myocardial damage. Aortic stenosis of this of the both valve and myocardium. One study report the patient with myocardium fibrosis checked by late gadolinium enhancement in myocardium. The mortality and cardiovascular mortality was lower than the LG absence group. So some authors say still unmet need for medical therapy to prevent and mitigate the risk of heart failure in patients with calcific aortic stenosis. So the aortic stenosis is a progression with the LV hypertrophy and LV fibrosis and cardiac remodeling. In this situation, the medical therapy targeting the LV and the valve and augmented LV reverse remodeling after AVL is necessary to reduce the high residual risk. However, the medical therapy of the aortic stenosis guideline is limited data on your RAS inhibitor and RNA with the class recommendation of 2B. In this situation, SGLT2 inhibitor improved the cardiovascular outcome in patients with heart failure, while the wide range of the ejection fraction, regardless of whether the patient has type 2 diabetes. And in addition, some imaging and clinical study proves the SGLT2 inhibitor was associated to improve the cardiac volume and function with the severe mechanism. So we to put the hypothesis, the novel SGLT2 inhibitor, ENAVO-gliflozin, compared to the standard of care group, therapy was significantly reverse cardiac remodeling and improved the clinical outcome in the patient who underwent successful TAVR. This is the ENAVO-TAVR trial. This entire summary of ENAVO-TAVR trial. The severe AS who underwent successful TAVR, we divide the two groups. One arm is SGLT2 inhibitor arm, and one arm is standard of care group. So study design is investigator-initiated, multi-center, double-blind, parallel group randomized trial, and stratification by baseline ejection fraction and diabetes status and eGFR. Intervention group is give the enavolglyphosine 0.3 milligram once daily, and standards of care group as give the placebo. Sample size is a supported trial design, and percent of primary endpoint is 30% in the standard of care group baseline on the multiple RCT, include the partner and sortabin, low risk, and TP-TAVR registry. So final sample size is 1,040 patients. Primary endpoints are major advanced cardiovascular event or hospitalization for heart failure at 1 year after randomization, was defined death from any cause and non-fatal MI and non-fatal stroke. Secondary endpoint as each component of the primary composite endpoint and composite renal endpoint and rehospitalization for any reason, and change in the cardiac volume and function assessed by serial echocardiography, and change in near class functional class, and serial change NT-proBNP. Inclusion criteria is a patient 18 years old and symptomatic AS. Patient was treated by the successful TAVR. Successful TAVR is defined about 2 and 3 criteria. Is a good positioning in one valve and good performance of prosthetic heart valve and no complication. Exclusion criteria is receiving therapy as SGLT2 inhibitor within the 4 weeks prior randomization, and type 1 diabetes and recurrent UTI and stroke event. And at heart failure with a non-infiltrated cardiomyopathy is also exclusion. So this is a summary. It's an ENAVO-TAVR trial. We will enrollment 1,040 patients and divide the 2 groups, SGLT2 inhibitor and standard of care group. This is not start enrollment. We do the process in the future. Thank you for your attention.
Thank you, Dr. Lee. Okay, so let's move to the next topic. Next topic is Define DM trial. Is Dr. Kim, please?
Thank you for your introduction. I'm Hoyun Kim from Sejong Hospital, and today I'm going to talk about Define DM trial comparing state-of-the-art PCI versus CABG in diabetic multivessel disease patient. I have nothing to disclose. There have been some previous trials comparing PCI and CABG in diabetic multivessel disease patient. Syntax trial enrolled 1,800 patients with left main and or 3-vessel disease, and their subgroup analysis, diabetic subgroup analysis, 452 patients reported that PCI was associated with higher incidence of composite of death, MI, stroke, or repeat revascularization, mainly driven by higher incidence of repeat revascularization. BEST trial enrolled 880 patients with multivessel disease, and they concluded that PCI was associated with higher incidence of primary composite of death, MI, or target vessel revascularization. And their diabetic subgroup analysis showed that in patients with diabetes and multivessel disease, the primary composite endpoint of death, MI, or TVR occurred frequently in the PCI group. And their extended follow-up study with median follow-up duration of about 12 years showed that there was no significant difference in the primary composite outcome rate between PCI and CABG, and also there was no significant difference in the all-cause mortality between PCI and CABG groups. However, their diabetic subgroup analysis showed that in diabetic patients, primary composite endpoint occurred frequently in the PCI group. However, all-cause mortality was not different between PCI and CABG groups, and repeat revascularization occurred more frequently in the PCI group. However, there are some limitations of prior trials. The Syntax trial and the BEST trial did not focus on diabetic patients, so they are just subgroup analysis with underpower. And the Syntax trial included patients with left main disease. There are 2 trials which included patients with diabetes and multivessel disease. They are Freedom trial and VARIANT-ICD trial. Freedom trial randomized 1,900 patients with diabetes and multivessel disease, and they showed that PCI was associated with higher incidence of composite of death, MI, or stroke at 5 years, and all-cause mortality was also higher in the PCI group. And Freedom follow-on study showed that all-cause mortality remained higher in the PCI group compared to CABG group. VARIANT-ICD trial randomized 2,368 patients with type 2 diabetes and coronary artery disease, and they showed that there was no difference in the survival rate between revascularization and medical therapy, and both in the PCI stratum and CABG stratum. However, 5-year MACE-free rate was higher in the revascularization group compared to medical therapy group in CABG stratum. So based on previous trials and studies, 2021 revascularization guideline suggests that in patients with diabetes and multivessel disease with involvement of LAD who are appropriate candidate for CABG, CABG is recommended in preference to PCI with class of recommendation 1, and who are amenable to PCI and poor candidates for surgery, PCI can be useful with class of recommendation 2A. However, there are many limitations. They did not use current generation DES, they did not frequently use intracoronary imaging, and they did not use optimal medical therapy of current practice. So which should be better, imaging and physiology-guided state-of-the-art PCI or CABG? To answer the question, we plan to conduct DEFINE-DM trial, diabetes-centered evaluation of revascularization strategy of functional and imaging combined state-of-the-art PCI or CABG in patients with diabetes and multivessel disease. This study objective is to compare outcomes of state-of-the-art PCI with CABG in patients with diabetes and multivessel disease with LAD involvement. A total of 1,360 patients with diabetes and multivessel disease who are equally eligible for PCI or CABG will be one-to-one fashion randomized to imaging and physiology-guided PCI and CABG, and the primary endpoint will be the composite of death from any cause, MI or stroke at 2 years. Patients with type 2 diabetes and with significant multivessel disease defined as greater than 50% diameter stenosis by visual estimation will be enrolled, and patients with unprotected left main disease, ST elevation, MI, cardiogenic shock or severe LV dysfunction, or life expectancy less than 2 years will be excluded. Primary outcome will be major adverse cardiovascular events, which will be defined as a composite of deaths, all-cause death, MI or stroke at 2 years, and secondary outcomes will be as follows. Conclusion. The result of the previous trials suggests CABG is better than PCI in patients with diabetes and multivessel disease. However, there are limitations for accepting those results in the contemporary PCI era. So DEFINE-DM trial would provide valuable evidence for comparing imaging and physiology-guided state-of-the-art PCI and CABG in patients with diabetes and multivessel disease. Thank you for your attention.
Thank you. Okay, let's move to the next talk. Is a fate main trial is by the Dr. Jung-Min Ahn. So actually, Jung-Min, I don't think that you should. You are not going to sleep. Meaning the so many trials you should do, right? Yes, it's better always non-sleep. Okay.
Yeah, thank you. So I'd like to introduce the fate main trial. So this is actually first live demonstration case of TCTAP 2014. So look at the left main. It is significant. Here's another view. It is significant. Spider view show that they're not that significant, but caudal view looks significant. Actually, there are extreme spectrum of left main disease. Left is very significant. Everybody agree that, but the right, non-significant. But in many our practice, it is significant. So there are lots of gradation. Then what is the criteria for the left main intervention? This is the angiographically diameter stenosis 50%. Random trial indication is diameter stenosis 50%. Based on the very long, all the studies, this study showed that bypass surgery improved patient outcome if a patient with the diameter stenosis 50% received the operation. But another important thing is the patient risk factors. Without risk factors, even though diameter stenosis is significant, the patient long-term outcome is good. So in addition, the intermediate left main disease, diameter stenosis 25-49%, no impact on the treatment strategy and long-term outcomes. But we know the significant left main is more than 50% diameter stenosis, but the left main CAG analysis is very poor reproducibility. So which is significant, left or right? FFR is 0.71. This is the 0.89. Left case is diffuse disease, so diameter stenosis is calculated diameter stenosis should be less than 50%, but right is looks tight, but I would show that I'm sorry, very eccentric the lumen. So it is very common. So angiographically and FFR difference. So usually left main supplying myocardium is the big. So even though there is mild stenosis, FFR frequently lower than cutoff value. So this is nicely demonstrated that OCT show that the eccentric. So FFR is very low. Some projection looks fine, but the other projection looks very tight. So previously we demonstrated that IVUS cutoff value 4.5 is associated with low FFR in the left main trunk. European studies show that the 6 square millimeter is associated with low FFR. So ESC guideline suggests that the FFR guided considered in the PCI, but IVUS was considered in the left main procedure. So recently, FFR and IFR in intermediate left main disease suggested relatively safe, but we don't have any critical case. Based on the literature, the default of left main disease generally safe, but can we apply the FFR concept in the left main treatment? We don't know. So we designed the FATE left main trial. We will enroll the 900 patients divided into 2 arms, FFR-guided left main PCI arms, angio-guided PCI arms. We'll see the 1-year MACE composite endpoint. This is inclusion criteria. Left main, de novo left main disease defined by the angiography 50% diameter stenosis visual estimation. This is exclusion criteria. Primary endpoint is the death from any cause, MI, hospitalization for unstable angina, heart failure, resuscitated cardiac arrest, lipid intervention at 1 year. This is the result of FFR value to our live demonstration. FFR is 0.79, very small minimal lumen area, so we put the standard long standing. Thank you for your attention.
Okay, thank you, Dr. Ahn. So it's now time for the discussions of the these 4 or RCT. So is there some comment or question?
Yeah, maybe we can.
Yes, okay.
Yeah, maybe we can just start with the FATE main trial. So, what about the post-optimization? So, after enrolling the patient, are you using 100% IVUS in both arms? The first question. The second is, in the FFR arm, are you doing a post-optimization with FFR guidance or not?
Thank you. Very important questions. In my center, we use the IVUS 100% in any cases. So definitely the both FFR guidance and angio guidance, we will apply the IVUS pre and post intervention. So regarding the post PCI FFR, this is not the guideline protocol recommendation, but we suggest that measured after the left main PCI, we will so we'll see this would be the impact on the patient long-term outcome.
And the inclusion is just by QCA in the
No, visual estimation actually.
Visual,
Yeah,
okay.
yeah, because
yeah.
This is very tricky, left main assessment.
Yeah.
The QCA left main assessment is very tricky. There is no standardization.
Yeah.
So many random trial, previous studies, any kind of studies, visual estimated diameter stenosis is inclusion criteria.
Okay.
Dr. Ahn,
So you're not allowed to do IVUS in the angio arm to decide about PCI?
No.
It's all
stent optimization only.
only, okay.
Yeah, yeah.
And is it, I guess thinking about it, the only thing I can see FFR helping in is maybe deferring some lesions that don't need PCI. Is this superiority or is it non-inferiority? Or
Superiority trial. Yeah.
Could you show us some standard method of the FFR measurement in left main? Is some you had some
Yeah,
guideline?
we actually the Bill is the expert in the left main FFR, but actually there is no standardized method to measure left main FFR. But particularly if there is tight critical stenosis in the downstream, the epicardial coronary artery, and so if there is a tight downstream coronary artery disease, we put the stent first, and then we measure the FFR. That's it.
Well, this might be also biased, right?
Yeah.
What do you think the left main FFR measure?
Yeah, I mean, I think it's challenging when there's downstream disease, and doing both the circumflex and the LAD and doing a very careful pullback, I think, are all important. But in many cases, you know, we also need imaging to help distinguish, because it's subtle. If there's ostial LAD versus distal left main, you can't always tell. And so I tend to use a combination of modalities.
I mean, the best would be to have only left main diseases, but you need a number of 930 patients,
Yeah,
which will
it's
be
almost
quite
impossible.
difficult.
Yeah, almost impossible to include the only left main. Particularly, osteo and shaft disease is the best target for this study, but practically, I think it's impossible.
Yes, I have a question for Dr. Park on the tailored chip trial. So in your tailored arm, you're using the 60 milligram of ticagrelor, which we know is associated with a little bit less dyspnea than the 90. But what are you doing in your patients who have dyspnea, who cannot tolerate the drug, and you need to switch? That's the first question. And the second, is your analysis going to be on an intention to treat basis or on actually treated?
Yes, we chose the 60 milligram ticagrelor because of East Asian population have less reduced ischemic risk but high bleeding risk. So we chose the most safe drug. So based on the Optima trial, we investigate we show that the antiplatelet effect is 16 milligram ticagrelor as well, compared with similar with 90 milligram. So we chose the ticagrelor 60 milligram. And before the Temporal trial showed that aspirin plus the ticagrelor in stable coronary disease is more reduced ischemic with increased bleeding risk. And then some situation different in trial Pegasus Timmy trial. This study beyond 1 year after MI, ticagrelor 90 milligram versus aspirin versus ticagrelor 60 milligram versus aspirin is similar ischemic risk and already no bleeding risk. So we chose the first 6 year, we chose the ticagrelor 60 milligram, and first aspirin is maybe better regimen in ischemic risk patient.
What if the patients develop shortness of breath?
Some need short of breath. As you know, that Pegasus Timmy trial 60 milligram ticagrelor is lower bleeding, lower DOE compared with 90 milligram. So in that place, in our patient clinic, some patients need DOE, so we change to Plavix to Cravioglare sometimes. But however, my short leader experience, ticagrelor 90 compared with ticagrelor 9 mg BID, ticagrelor 60 mg is less than 90 mg DOE.
Okay, other question or comment?
Yeah, one comment is I was a little bit wondering regarding the 12 months, right? Because we almost left that concept. So in complex PCI we go for 6 months, and basically between 6 and 12 months we don't see a big reduction on acute event rates, but basically a little bit more higher bleeding. So therefore I'm a little bit curious about your final slide that will change guidelines. I'm not sure. As well as we know from the ESA-REACT trial as well that prasugrel was superior to ticagrelor. You started 2019, you didn't have the data, but so I appreciate your final slide, but I'm not sure if it will definitely change practice.
Okay, Professor Bae? Yeah.
Dr. Ahn, I have one practical question. If you have some patient with eccentric left main stenosis is about 50%, and you enrolled this patient in randomized, and then patient have gone to the to the FFR subset, but then in FFR the value is 0.8. In these cases, how should we do?
Definition-wise, 0.8 is significant.
But if you
0.81
see
differ.
differ.
Yeah,
Okay.
0.81 differ.
Yeah.
Yeah.
Okay. In the just the less than 0.80,
Yeah.
we'll do PCI.
Yeah, do PCR.
Okay.
Dr. Kim, yes, I have questioned the defined DM trial. So from the many clinical trial comparing the PCI and CABG is sometimes usually the CABG better. Yes. When you see some comment is definitely in limitation or discussion is PCI not not image guided PCI but image guided PCI something is beatable or with the CABG. So my question is what's the optimization criteria? Is this criteria is only by image guidance or sometimes field is also sometimes physiology guided optimization also is suggested, or in this trial is both two strategy is also proceeded.
Yes.
What's the optimization?
First, optimization using imaging is we will use the published or released ESC imaging optimization criteria. So there were minimal stand area criteria or plaque burden, stent landing zone plaque burden over plaque burden, and minimal dissection, and so on. So we will use the imaging optimization criteria. And I think, and FFR, regarding FFR, we will use over 0.8 D4, under 0.8 to PCI. Yeah, that's our criteria.
And Dr. Kim, was there a reason for excluding left main disease? It seems like many PCI versus CABG trials, that might be one area where PCI does well compared to non-left main.
Yeah, the defined DM trial, thank you for your question. Defined DM trial was designed to compare PCI and CABG in patients with diabetic multivessel disease, not left main disease, because, for example, syntax trial, left main, and or three vessel disease, we think that it is difficult to interpret the outcomes according to regarding three vessel or left main. So it's difficult to interpret the data. So we just wanted to know that in left main, in diabetic multivessel disease without left main disease which would be good, PCI or CABG?
One question, which is I think important regarding the endpoint. I mean, basically, the endpoint is always triggered in those trials by TLR, right?
Yeah.
Target lesion revascularization. So I'm wondering because, and sometimes we see also a little bit more MI in the collective of PCI. So the question what I'm asking is, when the patient coming back with chest pain doing angio and you see the instant restenosis, are you going to do an FFR triggered re-intervention? So you know what I mean, because we have often we treat stenosis, instant restenosis, which are probably not necessary to treat because on the eyeball effect that we have, and I assume that we are creating a higher re-intervention rate than necessary in these trials.
I think that if a patient come to the clinic with chest pain and the angiography shows ISR, then without FFR we will do PCI, I think.
Yeah, that's the problem. So another question is, how is the CABG arm? So are all the CABG arm almost using RIMA as a standard of care, because CABG is so big priority nowadays as well, right?
Because of time limit, I I didn't include it. I didn't include, but in CABG, we should use Lima to LAD. Is mandatory.
Okay, thank you very much. I think we should move on to our next section here. And so Dr. Nam will now talk about EPIC-CAD trial, long-term antithrombotic strategy in AF patients with stable coronary disease.
Thank you, Chairman. EPIC-CAD is to explore the long-term optimal antithrombotic management in patients with atrial fibrillation and stable coronary artery disease. This slide illustrates the management scheme of patients with atrial fibrillation requiring oral anticoagulation, and both also have coronary artery disease after revascularization or acute coronary syndrome. With the advent of new oral anticoagulants and new generation DS, the duration of triple therapy is markedly reduced, and only transition from triple to dual therapy is recommended. And this recommendation is based on these multiple landmark trials from OST to Pioneer and Augustus and Entrust PCI. For patients with long-term stable coronary artery disease, the guideline recommends single therapy, single NOAC alone. However, this recommendation is not sufficiently supported by scientific background. So we designed EPIC-CAD trial, which is to compare the edoxaban monotherapy versus edoxaban plus single antiplatelet treatment. However, while we are conducting this trial, there were two papers published in 2018 and 19. The first one was OAC alone, and this trial compared the warfarin-based OAC mono treatment versus combination of warfarin plus single antiplatelet. Unfortunately, this trial was terminated prematurely because of very sluggish patient recruitment. So the result is not conclusive. The second one is FIRE, which compared the rivaroxaban monotherapy versus rivaroxaban plus single antiplatelet. The results showed that the single therapy arm was not inferior to the combination therapy, and more importantly, the single therapy arm showed significant, about 40% reduction in the bleeding episode. So the two trials are very important, but they have some limitations. The first one has used warfarin as the oral anticoagulation, and as the trial was terminated prematurely, the result is not conclusive. The second trial, FIRE, used new oral anticoagulant, but they used only low-dose NOAC, 70 milligram, which is approved only in Japan. So our EPIC trial will be the first trial to test this standard dose NOAC in this indication, and we recruited about 1,000 patients. And the primary outcome is net clinical outcomes of composite death, MI stroke, and ISTH major bleeding. Inclusion criteria includes AF with a high CABG score and stable coronary artery disease 6 months after revascularization if stable angina, and 1 year after revascularization if the patient has acute coronary syndrome. They were 1-to-1 ratio randomized, and edoxaban dose reduction was performed as guideline indicates. We first started in 2016, and first patient was enrolled in 2019, and 22, the patient enrollment was completed, and last September, the 1-year follow-up was finished. In conclusion, our EPIC-CAD trial will compare the edoxaban monotherapy versus edoxaban plus single antiplatelet treatment. And this will be the first study to test the standard dose NOAC in this patient with stable coronary artery disease and atrial fibrillation. Thank you for your attention.
Thank you. We'll have Dr. Jinho Lee come back up and now tell us about the PROTECT-HBR trial, new GI protection for high bleeding risk patients requiring antithrombotic agents.
Okay, thank you for your introduction. Today, my talk is a PROTECT-HBR trial. I'm Jinho Lee. The patient with cardiovascular disease such as coronary artery disease and cerebrovascular disease and peripheral artery disease, they are need to have a long-term antithrombotic therapy, even lifelong antiplatelet or lifelong anticoagulation. However, the antithrombotic therapy needs finding a sweet spot to reduce ischemic event and minimizing the increasing of the bleeding event. But the GI complications are the important and most common problem from the long-term use of antithrombotic therapy. The upper GI bleeding is more frequently in patients who take an aspirin or anticoagulant. And the patient who take the PPI is low risk of the upper GI bleeding. So the previous COGEN trial that comparing GI endpoint clopidogrel with or without omeprazole fixed dose combination, the trial results showed that there's no clinically significant cardiovascular interaction between PPI and clopidogrel, whereas there's a significant reduction the GI bleeding with the PPI use compared with the placebo. However, the Kambis trial that randomized pantoprazole 40 mg daily or placebo with aspirin or rivaroxaban or both them to take a patient, there are no significant difference in upper GI bleeding rate, but it's lower in the gastroduodenal lesion in the pantoprazole groups. So European guideline recommended concomitant use of PPI in patients receiving aspirin monotherapy or DAPT or anticoagulant monotherapy who are at the high risk of the gastrointestinal bleeding patient. The class of recommendation is 1 and level of evidence A. However, the concern of long-term use of the PPI is raised. The adverse effects include hypomagnesemia and osteoporosis and bone fracture and C. difficile infection, and the pharmacologic limitation, delayed onset of action, and incomplete exsuperation, and need for injection before the meal to achieve the maximum efficacy, and some significant drug-drug interaction, especially clopidogrel. And so this is about the concern of PPI. So in this situation, the novel type axis suppression agent, PCAP, have some advantages compared to PPI with no pharmacological limitation and less drug-drug interaction. The compared mechanism show the PCAP is a useful axis suppress and directly binding the potassium binding domain and reversible binding and no need to stimulate proton pump inhibitor. So we put the hypothesis the PCAP would be non-inferior to PPI, the respective the rate of primary composite endpoint or GI bleeding event in 12 months. This is a PROTECT-HBR trial. The patient with no cardiac or vascular disease receiving antithrombotic therapy who are at the high GI bleeding risk. We divide the two groups, the PCAP arm and PPI arm. We compare the GI bleeding outcome. Study design is multi-center and randomized double-blind and active control parallel phase 4 study and stratification by the participating center and type of antithrombotic drug, antiplatelet or anticoagulant. Also, the intervention group give the tegoprazan 50 mg once daily and rabeprazole 20 mg placebo group, and rabeprazole group take the rabeprazole 20 mg once daily and plus tegoprazan 50 mg placebo tablet. So this is non-inferiority trial and present a primary endpoint at 4 of the PPI group based on the previous COGEN and Kambis trial, and the dropout rate 5, and final sample size is 3,100 patients. The study endpoint as a primary efficacy endpoint, a Kambis endpoint upper GI clinical event. So this is defined by the GI bleeding, compounded by endoscopy or CT. So and the unknown origin, and bleeding when presumed occult GI origin, and drop the hemoglobin over 2 and hematocrit over 10. And symptomatic gastrointestinal ulcer or pain and GI obstruction or perforation is a set of endpoint. Secondary endpoint was each component of the primary efficacy endpoint, and GLD, and cardiovascular safety and endpoint, and coronary vascularization and peripheral revascularization. So inclusion criteria is over the 19 years of patient and chronic use of antithrombotic agent, either antiplatelet, OAC, and its combination. And define the documented cardiac and vascular disease, coronary artery or cerebral, peripheral artery disease, AFib, and valvular heart disease requiring intervention such as TAVI or TEER. So inclusion criteria is a definition of high GI bleeding risk is over the 65 years of age, and concomitant use of oral anticoagulant and any antiplatelet therapy, and long-term use of NSAID and high-dose NSAID, history of GI bleeding or ulcer and peptic ulcer disease. So this is a summary of the cardiovascular disease documented and use the chronic use of antithrombotic drug, and patient with increased risk of GI bleeding risk. The exclusion criteria is active bleeding or any contraindication of using the antithrombotic therapy, and concurrent use of PPI or PCAB within 4 weeks before randomization. And based on anemia and thrombocytopenia, renal failure, liver disease was excluded, and the other drug-drug interaction is excluded. This is a PROTECT-HBR trial. So the 43 participating center in South Korea, and now enrollment state is 7.4, and about monthly enrollment state is giving the increase about the 70 patient. Thank you for your attention.
Thank you. So Dr. Hanbit Park is going to come back up and now talk about the ASSURE DES randomized trial.
Thank you, Chairman. I talk about ASSURE DES randomized trial. This is my disclosure. Non-cardiac surgery is often needed after drug-resistant implantation. However, the maintenance of antiplatelet before non-cardiac surgery is a concern between cardiologist surgeon. Stop the antiplatelets sometimes cause of stent thrombosis and acute myocardial infarction and arrest. However, continuation maintenance of aspirin or perhaps will make post-op bleeding. Previous POISE-2 trial, which is comparing is aspirin with aspirin or without in non-cardiac surgery. Maintenance aspirin is not reduced. That's rate of death and non-fatal MI, and aspirin increased in major bleeding. However, this study of subgroup study with previous PCI history, in patients with previous PCI history, the aspirin reduced the rate of death or MI and without increasing major bleeding. And this data from Severance Hospital, total 2,100 patients enrolled. In current daily practice, about 57% of patients is continued aspirin during non-cardiac surgery and stop aspirin 43%. However, continuous aspirin is not reduced MACE and ACE. And in another registry, COMET registry from Korea, total 3,600 patients was enrolled. This data was 50-50, and stop the aspirin 15 and maintenance aspirin 15. However, aspirin did not reduce that clinical outcome and major adverse event and major bleeding. So in current guideline, ESC guideline, in patients with a previous PCI, it is recommended to continue aspirin perioperatively if the bleeding is allowed, 1B. And for patients under high bleeding risk, such as intracranial surgery and spinal surgery and vitreoretinal eye surgery, it is recommended to interrupt aspirin for at least 7 days preoperatively. And American guideline, inpatient treated after PCI, undergo surgical procedure, stop the pitfall trap and aspirin more maintain. However, there is a gap in current evidence. Most of study observation study, it has a selection bias, and one of subgroup analysis of POISE study is a subgroup studies has so small sample size to underpowered and subgroup analysis. So we designed the ASSURE-DS randomized trial. We randomized controlled with aspirin or without aspirin during the non-cardiac surgery. And DS implanted more than 12 months prior to surgery, and patients without acute coronary syndrome and recent MI, and elective surgery without intracranial, intraspinal, lateral surgery. Total 900 patients was enrolled, and aspirin-only patient 450, and non-aspirin patient on 450. This study is comparing the clinical efficacy and safety of antiplatelet therapy in patients undergoing non-cardiac surgery for more than 12 months after PCI with DS, and the trial compared the outcome of discontinued antiplatelet treatment group and aspirin group. This study primary endpoint is coupled of death, stent thrombosis, and MI, and stroke. Included criteria is who had implanted one or more DS and scheduled the surgery at more than 12 months after PCI, and elective non-cardiac surgery. Excluded criteria is currently have ACS or MI within 1 month, and symptomatic severe LV dysfunction and severe valvular heart disease, and need for anticoagulation and emergent OP and cardiac surgery and high bleeding risk OP. The sample size is based on the POISE-2 trial. We randomized 900 patients over 12 months after, and aspirin group and aspirin stop group. The trial procedure is patients are randomized to aspirin or non-antiplatelet group. Aspirin group takes only aspirin from 5 days before surgery, and patient on single P2Y12 inhibitor change to aspirin from before 5 days, and patient on depth change to single aspirin from 5 days before operation, and depth is resumed post-operative as soon as possible. And non-antiplatelet group discontinue all antiplatelet agent from 5 days before operation, and antiplatelet agent is resumed as soon as possible after operation. All patients are followed by OPD or telephone call. Current status up from March 2017 and March 2024, a total 900 patients were enrolled. This year, the primary data will be available. This is my last slide. The ASSURE-DS trial is a prospective multi-center and randomized study to compare the safety and efficacy of aspirin stop or not in perioperative period of non-cardiac surgery in patients who have undergone PCI with DS for more than 12 months. It may help to determine the optimal antiplatelet therapy in patients who underwent PCI with DS before non-cardiac surgery. Thank you.
Great, thank you, Dr. Park. And last but not least, Dr. Jung-Min Ahn will come back up and now talk about the VARIANT-ICD trial.
Yeah, thank you, Bill. The final subject is variant angina and sudden cardiac death population, VARIANT-ICD trial. 62-year-old gentleman aborted sudden cardiac death, and in Korea, usually will be performed the coronary angiogram and stimulation test for coronary spasm. E1, E2, E3. So our diagnosis is the cardiac arrest due to variant coronary spasm. So then, what is your treatment? Dominick, what's your treatment in this page?
Give some nitro.
Yeah. Then Bill or Kambis, what is it? The European.
Well, at the moment, I mean, definitely, I mean, you have indication for ICD, I think, right? ICD implantation. And I mean, for the patient care, you can give nitrates, ranoleucine, yeah. But survived cardiac death, right? So with VF. So
After nitro, the fully dilated and reperfused anyway. But the guideline, ICD guideline is a little bit tricky. The ICD should be implanted after to exclude any completely reversible cause. Coronary spasm is a reversible cause or not? Spasm itself is reversible, but the patient characteristic to induce the spasm, is it reversible? That is our fundamental question. So previously, the 8 years ago, we gathered the variant whole patient in South Korea. We gathered 172 patients who suffered from the sudden cardiac death due to the variant coronary spasm, and to compare the other variant angina without aborted sudden cardiac death. The variant angina patient, 10-year follow, very low rate of mortality, cardiac death, but presented with the aborted sudden cardiac death, the high risk of mortality during the follow. This is a retrospective analysis. We didn't know what medication, how well patient get a medication regularly. Ventricular tachycardia event is very high. Cardiac death and ventricular tachycardia event is also very high. Some patients have the ICD implantation. In Korea, so far, ICD is not indicated in patient with presented with sudden cardiac death, even due to the coronary spasm. So, but the limited number of patients received ICD, 24. Very interestingly, ICD patient, look, this is the ICD shock, appropriate shock. Even though there was appropriate ICD shock, the mortality is 4.3, but without ICD, there's 19.3%. So statistically insignificant anyway, mortality increased the patient without ICD. Another registry data from the whole South Korea, data from the Korean health insurance data, the Samsung Medical Center published this data. Arrest patient is around 600, without arrest 6,000 to compare the outcomes. The without arrest 6,000, with arrest 600. All event is higher in patient with arrest. Cardiac arrest, in hospital mortality is high. During the follow, recurrent cardiac arrest, arrest or MI is increasing. In addition, ICD patient, no death. Without ICD, higher death rate. So we designed variant ICD trial almost 7 years ago. We are enrolling patient up to, we try to enroll, our target population size is 140 patient who manifested as a sudden cardiac death due to variant angina. Then we will randomly assign to the ICD treatment or optimal medical treatment. So this is eligible for the trial. So positive provocation test is a definite inclusion criteria. The ergonomin coronary CAG. So primary endpoint is death from any cause at 5 years. This is secondary outcome. So ergonomin CAG is very important. To exclude the less conclusive coronary spasm, we only enroll the patient who have a total occlusion or subtotal, already 90% occlusion. Diffuse intermediate narrowing it's not the patient to include this study. This is not that indication, not that inclusion criteria for this trial. This is a definite indication for this trial. So optimal medical therapy, the lifestyle modification, and at least the 2 vasodilator therapy for patient, calcium channel blocker and long-acting nitrate. ICD implantation is patient also receive the optimal medical treatment using at least 2 vasodilator therapy. Sample size is, actually this is a very hard trial. The sample size is only 140. So this is a variant ICD patient. So far we enrolled 90 patients. We have to go the 50 patients more, but very hard. 1 year, maybe several patients only. It took 7 years. 7 years we enrolled 90 patients. I think we need more next 10 years or something. Thank you for your attention.
Great, thank you, Dr. Ahn.
Yeah, I actually had a question for Dr. Ahn before. I remember years ago we did these tests with ergonovin when I was working in Rome. But one of the things that we were doing, we were also repeating the test after optimizing medical therapy because most of these patients that are positive, they're on no therapy.
Yeah.
So you're just randomizing off the bat, correct?
Yeah.
So just a short question. Do you already have some crossovers in the group? I mean, you know, patient without ICD that will have another event and then they get an ICD, you know, because of the intention to treat in the low numbers? How?
Yeah, actually, patient have two sudden cardiac deaths. That would be a definite the indication for ICD. So crossover, but we don't know how many so far. Yeah.
Dr. Ahn, actually, the recent days, we don't have any ST elevation or variant angina patients with stable vitality. We just admitted, you know, the unconsciousness of sudden cardiac arrest patient, but the variant angina patient in this subset in our hospital is not uncommon. And so if you permit, then, you know, we can enroll that kind of patient.
Thank you very much. Thank you. So this is good for patient because actually we don't know. But the many EP doctors want to implant the ICD, but currently Korean regulation did not permit the implanted ICD so far.
Yeah, actually, that is one of my fault. You know, I have discussed with so many times with the HIRA and the Ministry of Welfare, with this kind of subset. But they always told me, you know, there's a lack of data, and so there is big problem.
So, Jung-Min, so is there any plan of the long-term change of the ICD? You know, I'm not sure, but the device is a patient do not pay for the right. But 10 years ago, 12 years ago, so at that time also, if not Korean insurance did not change. Yeah, so Asan medical centers always support.
So fortunately, we got a fund from the ICD company. So the initial ICD implantation, ICD arms, we can provide the ICD without a charge. But I discussed with the EP specialist that after 8 years no event, then my EP specialist said to me that he said that no need more. Yeah.
I have a question for Dr. Nam. I'm an investigator of a FIRE trial. I'm very glad that finally next trial is coming. So if we were to do a superiority analysis in the FIRE trial, there's even mortality benefit in DOAC single arm. So my question is, would you do mortality benefit analysis in your trial?
Yes, it's included as a second endpoint, but the primary endpoint is a composite of yes.
Yes. Great. Thank you very much.
I have a question for Dr. Park. So I'm very interested on the topic of antithrombotic management of patients going to non-cardiac surgery. So my question for you is, your outcomes will definitely depend on the type of surgery, because there's a variation of ischemic risk which may define your outcomes. Are you stratifying according to type of surgery or not?
Or we doesn't stratify type of surgery. We doesn't stratify this only center.
So really a similar question is maybe the DS type, meaning the first generation DS, and also PCI type is also important. Is there was no included in the stratification strategy? No. No consider.
No stratification. So that's a good point. We will analyze the post-hoc analysis, the stent type or stent clinical anatomic factor is a very good point.
Other comments from the panel or questions?
I just want to ask about Dr. Nam about the EPIC coronary artery disease trials. I mean, the trials already, I think now you have already 1 year, right, observing. Do you see any trends?
We are analyzing the results.
Major bleeding in the endoxapan and
Major determinant seems to be the bleeding episode.
Bleeding.
And safety efficacy endpoint does not seem to be big, significantly different,
okay.
but we are still analyzing. So,
all right.
Great. Well, I'd like to close this session. I'd like to thank the great presentations and presenters and also the panelists for their engagement, and hope everyone has a great day.